Hello there, this is Trishella Lespinas here today to go over my clinical rotation that I had both at Arrowhead Regional Medical Center and Mesa Clinic, and this is for the class NUR 645. And what I want to first start with, I want to start with the description of the facilities I had. Arrowhead Regional Medical Center, which is where I'm going to start with first, is a very large county hospital that covers a very large scope. It covers the cities of all the way up from Big Bear all the way down to, I would say, Redlands, down to Fontana, and all the way down to Rialto. It covers a large amount, and it also covers a lot of people that are underserved. So it is very much highly utilized, frequent, continuously. Within Arrowhead Regional Medical Center, we have a separate building that is for our behavioral health. Our behavioral health is very interesting since that it has a psych triage, which is like an emergency room, and then we have 4 units that we have. And within those 4 units, we have a total of 90 beds, and that's a large number of beds. Something also unique to Arrowhead Regional Medical Center is that we also have the county court system. So all of the other hospitals that have a psychiatric unit come to Arrowhead for court, for rehearings, for any type of hearings that they may have. So we're talking about Loma Linda VA, we're talking about Loma Linda Behavioral Medical Center, we're talking about Redlands Community Hospital and their behavioral unit, we're talking about Community Hospital San Bernardino, and even sometimes Canyon Ridge. So that it is frequent very much, a lot. We have a lot of students that come through there. It's a teaching hospital as well. So we have residents, we have nursing students, we have LVNs, and we have psych techs. And when I was working there as a clinical director, I also started having the nurse practitioners, which was a relatively new endeavor. So we were able to get contracts with Azusa Pacific, Loma Linda, Western Governors, and also Brandman University. In addition to that, Arrowhead's also contracted with Department of Behavioral Health. The DBH, or Department of Behavioral Health, is a very strong tie to us. They help with resources, and they pay a lot of salaries and money for a lot of different things. The Department of Behavioral Health has a say into, they're one of our bigger stakeholders in Arrowhead Regional Medical Center, and it's also another county entity. Within Department of Behavioral Health, there are also county clinics. One of them may be Phoenix Counseling Clinic. We also have Vista Counseling Clinic, and we also have the Mesa Counseling Clinic. And that's where I'm going to stop right there because that's where I was also doing supervision hours there as well. The Mesa Clinic is one of the largest clinics that we have, and once again, it serves the underserved area of San Bernardino. It's not too far from Arrowhead Regional Medical Center. It's approximately about 2 miles away. And it's a very large, like I said, clinic. We pretty much have a total of 10 psychiatrists that work there. There are also other different disciplines. We have LCSWs, licensed marriage and family therapists for treatment. They also have psychiatric nurses. They have psych techs to help for med pass and also long-acting injectable medications. And then, of course, we have clerical staff as well, too. It is a very large facility that also handles children, adolescents, and also adults as well, too, and goes all the way up to age 65. Within that being said, while I was there at that facility, I want to move to the difference between the two, which is really quite interesting. They both have a large clientele of lower socioeconomic individuals. However, the type of preceptorship is different. At Arrowhead, you have mostly clients that come through that have been brought in by the PDs. So therefore, you have a lot of 5150s. You have a lot of people that come from some of the other crisis walk-in centers, Marengo Basin that comes in. So we have a variety of different people that come to us, but they generally are on 5150s. Very rarely do we have people that come in voluntary. As a result of that, it is very fast-paced, and especially in the psych triage, the way of preceptorship is more so more emergency med, giving more emergency meds, giving emergency IMs, and stabilizing the crisis very immediately. When you move to the inpatient unit of Arrowhead, you have a little bit more treatment there. They do have LCSWs. We do also have licensed marriage and family therapists, and they are able to do treatment groups. But once again, though, the treatment groups that they do once is to stabilize a crisis. They then find placement for them out in the community, discharge planning, and of course follow up with one of the DBH clinics like Mesa, Vista, or Phoenix Clinic, as I mentioned beforehand. Generally, the stay at Arrowhead Regional Medical Centers has been, you would say, about 14 days. Most patients go to 5250. And when I was there as preceptorship, I would say that my preceptors were more fixated on trying to stabilize a crisis. They didn't use any medications that were different than what they did in the clinic. They used more long-acting, well, not as much long-acting. They did more of like the Cyprexas is what they used a lot of. And then they used a lot of the sleepers as well, like the trazodones and the temazepam. They used that as well. But pretty much they did a lot of trying to get the patients out as quickly as possible. Those who had to stay 5250s were only those that were really in a crisis and they couldn't find placement. But for the most part, they just thought really quickly to get them out. Another thing that's very interesting with Arrowhead is that they also did consultations. The residents and also the psychiatrists did consultations for 5150s that were in the medical floor. Those who were in the medical floor had medical issues first, and those medical issues had to supersede the psych issue. So that was a very interesting thing as well too, because when I was precepting with those different physicians and going to the medical floor, we were just getting a little background information, and more was just finding out when the person was being able to get stabilized in the medical issue and then be transferred to the behavioral health. They would start them on medications, but there was no treatment that was following through. They would not get psychotherapy. They would not get any follow-up because they were actually the main house. And so our biggest goal was to get them to behavioral health as quickly as possible. So the preceptorship for that was more of just finding out how the patient was doing on a day-to-day basis every day. We did not do treatment teams at all when we went to consultation. We just pretty much talked to the nurses that were there and helped to prescribe medication, find out how the medication was making a change while they were on the medical floor. The interesting thing with Arrowhead, I felt it was very fast-paced. It's a good thing, but however, we had knowledgeable doctors that were there, but Arrowhead tends to have doctors that have been there for many, many years, and it's good and bad. The training that they've had for many, many years, unfortunately, those who were on the inpatient unit, it appeared to be not as up-to-date, and this was kind of confirmed when I spoke with a lot of the residents, because you have new residents that come in and learning about new drug management, and the older doctors were not as keen as wanting to go with that route. And so therefore the newer residents were limited to going with what the attendee wanted them to have. And that was kind of discouraging, I would say. And that's what I found more so on the inpatient. And also on the triage, I found that to be the case too. I found that in triage, the residents were overwhelmed and they weren't able to really to provide as much care as they wanted. So when I was there doing my preceptorships there on the weekends and in the evenings, it was good because I was able to gather more information than what they had a chance to do, because they allowed us to have time to do that, which was very good. On the other hand, being over at Mesa Clinic was a different experience. I was with Dr. Rennie. Dr. Rennie is he is a board-certified psychiatrist and also neurologist as well. He is very big in focusing on the brain and how the brain can become maladaptive based on drug use and based on sleep and the use of caffeine and the use of just smoking, a lot of different variables. He was very focused on making sure that I knew these factors inside out. His way of precepting was more of making sure that I had the knowledge base. He felt that too many people, including residents and medical students and also nurse practitioners, did a lot of studying with big books, but they didn't master little books that really helped go deeply with the diagnosis, with medication management. So he spent a lot of time grilling me on medications, grilling me on what part of the brain it focused on, grilling me on making sure I knew how it affected the brain, grilling me on making sure that when I spoke to patients that I was assessing all levels of maladaptive behavior, such as, like I said, the use of caffeine, the use of energy drinks, the use of cigarettes, the use of their sleep, how much, how long, how much daytime sleepiness. So his style of preceptorship was more comprehensive. I would say much more than Arrowhead. Arrowhead was just more of get in there and do the best you can as quickly as you can. At least that's how I felt. But with the outpatient, it was much more thorough. Dr. Rennie's approach felt that it was important that we may be the first step that a person may have between saving their lives. So he felt that it was very important that I was, or all nurse practitioners and all psychiatrists, that we are proficient in our assessment so we can save lives, that we don't kill anyone. That was his biggest word, he always said, that we didn't kill anyone. And I found it quite interesting with Dr. Rennie because a lot of doctors do not want to precept nurse practitioners, but he felt the reason why he chose to do it was because he felt that there was such a need for providers in the area, and he much rather train a provider well than have subpar people getting care. And that was his whole premise and things. And so I do truly appreciate that. He was very challenging. He was very difficult, and he constantly continued to push the status quo, not just with me, but also with the resident, making sure that we knew everything. And we did that through case formulations. We had to present cases, and that was ongoing with his style of preceptorship. I was interested. It was interesting that Dr. Rennie also was one of the bigger ones with the clozapine clinic. From what is been told to me was that clozapine has not been used in Department of Behavioral Health or the county very well because of course, the issues and side effects associated with it. Dr. Rennie has practiced and studied in a lot of different places outside of the United States, like Australia and Great Britain, and so he says that clozapine is widely used, and so he was one of the bigger ones that wrote a white paper, and he presented different places about the use of clozapine, and so therefore he has a clozapine clinic there, and it's been very interesting being a part of the clozapine clinic because I've seen a lot of successes with that, and so that has been very interesting, very exciting. This is different than Arrowhead because Arrowhead doesn't use clozapine at all whatsoever. It being a big hospital, they do not. Matter of fact, Arrowhead does not even use a lot of the LAIs upon discharge, which is what Department of Behavioral Health clinics like to see because in the clinics they use long-acting injectables. So that's a difference between the two. And with the clozapine clinic, I have had the opportunity to be a part of and also see my own patients. Dr. Rennie's style of allowing me to precept is to be able to see my own clients and to be able to assess. And his whole style was for me to go into a separate room to do my own psych eval, and then once I complete the psych eval with the patient, I would have to come with him and present to him in the presence of the patient every single last thing. Now that was very daunting at first and very intimidating, but I did get used to it after a while. In addition to that, he also had me to give what will be my first choice of medications. And that was also very scary. But I also learned through the course of time with him the standard course of medications for different diagnoses. So that was very helpful, very exciting in that regard. So I really appreciate that with him. With the Arrowhead, I also got a chance to see clients as well too, but the preceptors did not ask me what was a line of medications. They did not ask me, they did not grill me about case formulations. They did not ask me about those things. I just pretty much saw patients, told them what went on, and they said, okay, thank you, and they went ahead and prescribed what they thought, and that was it. Yeah, surely they may ask me what the medication was for and what I thought it was for, but not to the level it was for the outpatient. So that was something else that's very, very different with the outpatient as well too. So, you know, I think that when we look at the experience I had a really great experience, I would say, with it. My experience with my patients was great. They taught me a lot about drug use and about how medications work for them and looking at the differences of looking at how it's important to look at what's cost effective for the patient, what costs them more. You know, sometimes we may want to prescribe medications and it may cost them more money, and that's something I think as a prescriber you have to look at. How much is this going to cost the patient? So outpatient really taught me that more so than inpatient, and so that was very helpful, and the patients taught me that as well. That was very helpful too. And I would say I would definitely recommend outpatient with Dr. Rennie, who's really good. I really appreciate that, or the clozapine clinic. I think I would recommend that for any student. It gives a nice little balance, both inpatient and outpatient. They both have their pluses. Inpatient's fast paced, it moves very quickly, it's not boring, it's exciting. Outpatient can be kind of slow, although, Mesa is very busy. It's very busy, fast paced as well. We saw a lot of the same type of clients, those who were depressed or anxiety, those who were had schizoaffective disorders, hearing voices. But it wasn't as exciting as Arrowhead. Arrowheads were exciting. You never knew what you were going to see, so to speak, and that's the kind of part that was kind of different. But on the other hand, outpatient, I saw more successes, and that was really great. And it kind of like solidifies why I'm in this course of wanting to be a nurse practitioner, because I saw a lot of successes, especially in the clozapine clinic. I can't stress that enough, the use of clozapine, especially for those who have treatment-resistant schizoaffective or treatment-resistant schizophrenia. And I have seen wonderful results with that. And surely, yes, it has to be monitored and it has to have the blood draws and, looking at the labs. But I've seen through Dr. Rennie him being very, very poignant with that. And as a result of that, has really taught me a lot. I have learned some skills that are similar from him, and I think that I have already adapted a few of them, because when he sees clients, and yes, I sat in on some of his clients. When he saw clients, I was not to interrupt, and but when I saw my own clients, that was separate. But when I saw his clients, at least in the very beginning of the rotation, I saw his style, and his style was he would get really involved with the patient. He tuned out everything, and he said that he was really trying to see how it was to be in his patient's shoes. And he felt that as a psychiatrist, it was important for him to really see what it was like to walk in the shoes of that patient. And it was his job to make their life a little bit better. And I thought that was very interesting. And so I kind of adapted that a lot. And I think that was a wonderful takeaway from that in that sense. So, as I end this whole evaluation, I want to say that I am greatly appreciative of the opportunity. I definitely think it's a wonderful experience to do both outpatient and inpatient. And I would recommend this to any student in the future. I feel like I have learned a lot when it comes to prescribing medications. I've learned a lot about the side effects, because I've been drilled about that constantly. I've learned a lot about incorporating other disciplines. Because I've already have an LCSW, I interacted very minimally with the psychotherapy, but I did refer a lot of my clients over to the groups and to the individuals for individual therapy. And I did get a chance to spend a lot of time talking with the therapist and sharing what their treatment modalities and how they go about doing things. And CBT is used a lot, and a lot with the ACT as well too. So it was really great, and I'm really thankful for it. I hope as I go forward that I can continue to take some of these experiences and take them home. I'm glad that I'm choosing the field of nurse practitioner. I'm thinking about adding the other certification of FNP, because I do think that there's a place for that even in psych, because we have patients that have medical issues as well, and I think that that's something important that needs to be addressed in the clinic setting as well too. So yeah, I think this is a wonderful experience. So this ends my long, lengthy signature assignment evaluation. Thank you for listening.